Good afternoon, everybody, and welcome to another episode of Figuring Out Fertility. My name is Carolyn Dubé. I'm the Executive Director at Fertility Matters Canada. It is day four of Canadian Infertility Awareness Week. It's Wednesday. We're all wearing green to celebrate infertility here in Canada. So I'm really excited today to be inviting a very good friend of our organization back to our table. Dan Nayat is a reproductive endocrinologist. He is the medical director at the Fertility Partners and also is now with RCC, the Reproductive Care Center in Mississauga. Is that right?
Yeah, that's right.
Awesome. So Dan, thank you so much for being here. I'm really looking forward to this topic specifically because, we talk a lot about sort of what to expect at your first IVF appointment or first fertility specialist appointment. But quite often people move on to a second round. So I'm really excited to learn things that we need to consider before actually moving into another round of IVF.
Okay. Well, thanks for having me. I used to be part of the executive board of Fertility Matters Canada, but I feel like I still am, although not officially.
You are definitely.
Proud to be here. How do you want to run it? Do you want to do maybe 20 minutes quick?
And yeah, so we'll do, you can present 20 minutes. If you're watching live, please know you can ask questions in the chat option on Zoom or in the comment section of Facebook. I will moderate those and Dr. Nayat will answer those for you live today.
Yeah. So maybe what we'll do, let's aim to make this interactive. So rather than you guys listening to me, if you want to interrupt, ask questions, it makes it more fun for everybody involved. So feel free.
Awesome.
So I guess today we'll talk about, oh shoot, the first cycle didn't work. What should we do next? I would say half of the consults that I see are second opinions, and a lot of them, unfortunately, had already not succeeded in an IVF cycle. And I'll sort of tell you my approach, what I see when I see couples, and hopefully that's helpful for anybody going through this. Okay.
That's awesome.
So 20 minutes doesn't do it justice. So I'm just going to do super high level. My background is mathematics. So I like to think through things logically, and yeah, hopefully you can follow along. Here we go.
Perfect.
Okay, this is my personal philosophy on IVF. So there is nothing I can do or anyone can do or you can do to guarantee success. But I think the name of the game is optimizing. So making the right decisions, controlling the things we can control to try to optimize it. My analogy, I don't know, I gave a lecture actually last night. A lot of this is overlap. So if you hear the same jokes, I apologize. But the analogy I sort of give is like, if you have a dice and you need to roll a 1, you got a 1 in 6 chance and you roll it, you hopefully roll a 1. But if you can switch that dice to only have 4 numbers, you have a higher chance of rolling a 1. So you want to optimize your chance, but it doesn't guarantee it. Okay. The next thing is, I think all decisions from the clinician and the patient should be based on rational choice, right? So, whatever it is you do, adjust this way, at least should be logical. Okay. I like to, when you fail an IVF cycle, I guess me personally, I have a little bit of an advantage because I get to look to see what happened. And you look for data and trends, and again, just use logic to figure out what you think could do to optimize. But the key part here is like personalization, right? So we as doctors, we're pretty good at writing exams. So if you gave us the facts, like this is the sperm count and this was her lining and this was the embryo grade, we can make fine decisions, but you got to listen to the person in front of you and listen to what they want. So for example, sometimes that could be like, I don't know, religious implications. Traditional IVF where you put thousands of sperm around the egg might be okay for one person, but the idea of selecting a sperm and drilling it is just not okay. Cool. Listen to that patient and work around. Sometimes it's like financial or circumstances. Partner lives in a different country, we have to use frozen sperm, something like that. Put these 3 together and come up with a plan. Okay. Any questions, Caroline? I'm going to bug you if no one's got one.
No, not yet. You're doing great.
Okay. Thanks. You're like egging me on as I go. That's good. Okay. The first thing is, usually if we're saying, hey, I want to do a second IVF cycle, we make the assumption that, hey, the first IVF cycle didn't work. Okay. I think it's important we figure out what is a successful IVF cycle. So for example, I think as fertility doctors, if one cycle led to one single healthy live birth, we succeeded. Okay, in our point of view, or at least my point of view. For the patient, they experience it, and their definition of success might be different, right? So if I have somebody who does IVF and gets 12 eggs and has one normal embryo, I'm thrilled because maybe that's going to work. That patient may not be thrilled because like they were hoping for multiple and they were hoping for, so our level, and a lot of that has to come with like managing expectations. Where I thought we were, where the patient may not always be aligned. A good example I'd like to give is the patient versus physician experience. So for example, I'm going to pick on you, Caroline, all the time. So you went through IVF and you got, 14 eggs and, 9 fertilized and you made 5 embryos. And, nowadays we're doing 1 embryo at a time. It's the safest thing we could do. So first one didn't work and the second one didn't work and the third one was a miscarriage and the fourth one didn't work and the fifth one worked. I stand up and I say, brilliant. It worked, 100% success rate. Congratulations. You have a brilliant doctor. So happy for you and things like that. And you say, are you kidding me? That was a 1.5 years of like craziness and we're 1 for 5. So even though, so we experienced the same thing differently.
Yeah, it's a good point, actually.
So I think it's really important that you know your expectations based on, let's say, cycle start, you sitting in front of me. What is the odds of you being successful when all those embryos are done? Versus, let's say, euploid transfer. A lot of times, like, especially in Google News and the media, you might hear, come to Clinic Z and take this supplement and try this co-treatment, and our success rates for 40-year-olds are 70%. And I say, wow, that's really good, right? But what they didn't tell you on the other part of that sentence is if you have a genetically normal tested embryo in a normal uterus, right? And not, which is fine, but not every patient is going to go through IVF in those circumstances and get a normal embryo. So it really depends what you're dividing your success rate by. Okay.
I think that you hit a really good point there, Dan, that sometimes expectations of the patients are different or maybe misunderstood from what was actually being sort of explained to them in the clinic. And we see that sometimes in our support groups, and people get frustrated or angry. So I think that from the very start, ensuring that as a patient, you have very clear discussions and set very clear expectations with your physicians so that you are on the same page. I think that's so important to avoid disappointment and future.
So I think that's critical. So the open communication and closing the loop and make sure the person in front of you also understands is, like, I would say, one of the most important. So another common example that we see is at the egg retrieval. Anxiety is high. We took these drugs. We have these follicles. I can only see follicles. They're black circles. I can't see eggs. Those are microscopic things. We all do our best and we safely drain each follicle and then we find out how many eggs, right? If you had 3 growing follicles and you have 3 eggs, that patient is thrilled. They're hit 100% of what they were thinking. If that patient has no clue how many follicles they have, but Google told them that the average 34-year-old has 12 eggs and she got 3 eggs, she's devastated. Even though we as the doctors are jumping up and down and saying, nice, we're 3 for 3. She thought she's 3 for what she expects 12. So you gotta make sure everybody understands the expectations.
That's so true.
Okay. So
we've got some questions starting to come in. Do you want me to jump in with those, or do you want to keep going? Okay. So after having a failed IVF cycle, 15 eggs retrieved, 14 fertilized, 0 blasts, how long would you say a person should take between trying again? I guess what I want to know is how much time is needed to try to improve egg quality. Can egg quality be improved if eggs are granular or slow growing?
Okay, so very good question. I'm sorry, that definitely counts as a failed IVF attempt, which is a horrible thing to go through. If it's okay, I'm going to take that and do it at the end because it's going to make more sense when I put a few more slides.
Perfect.
Okay. So first thing you need to know, either through your doctor, what is my chance of success? The next, if you want, there's a lot of free online calculators to give you an estimate. And it should be similar to your, it should be similar to what the doctor's saying, at least ballpark. Are you 10% chance, 50% chance? This is almost a guarantee. And if it doesn't work, something weird happened. You just need to understand that. There are some software programs that do it as well, but there's a lot of free tools for you to get an estimate. So know your estimate. Okay. Next. I think everyone will agree that a failed IVF cycle means no live birth, but we also experience it differently, right? So there's different stages of failure, and the question that you just had is a good example of that. So are you not able to grow follicles, or you can grow follicles, but you're not able to get eggs, or you can get eggs, but they're not fertilizing, or they are fertilizing, but not making to blastocysts, like that example, or they are making it to blastocysts, but they're not good quality or genetically been tested to be abnormal, or you're making beautiful embryos, but they're not implanting, or they are implanting, but they're not making their way all the way to term. So it's really important you figure out where the bottleneck is, okay? My team has recently made fun of me that I keep using the word seed and soil, and I probably stole that from somewhere, but I've been saying it for so long that I'd like to pretend I made it myself.
I think that's great. You should probably patent that.
Yeah, I'm gonna get like seed and soil t-shirts.
Yeah, I agree.
What I mean by seed and soil is seed represents the embryo and soil represents the endometrium or the environment. And we're trying to figure out where's the issue. We weren't able to generate a good enough, high enough quality embryo, or we did, and it's something related to the implantation or the environment. And I think that's important because we got to think of the extreme backup plan. I never sort of say that's the backup plan, but like, are we one day talking about an egg donor because we need a new egg, or a sperm donor because we need a new sperm? Or are we one day talking about using a surrogate? Okay, that's the triangle that I sort of think about. Okay. Okay, so you failed an IVF cycle. The question is, what now? And again, it's really important, expectations versus reality. Were your chance of success 2%, and then you failed, and we all say like, I'm sorry, like this is unfortunately what we expected to happen. We could talk about how to try again or optimize, or were your chances 90% and you were far from successful, and where is that huge gap, right? And then you start thinking like, what are contributing factors to that? Okay. Again, so here, there's many examples, but I think this is a common one that I see. So for example, the doctor and the patient expected a good number of eggs because they said you have a high reserve, you should respond well to the drugs, and we didn't get that many eggs. So sometimes I see patients, they say, doctor told me I had a high reserve, and I only got 3 eggs at the end. And I say, okay, so what happened in between these two things? And the question is, okay, was it not enough drugs, right? Mm-hmm. Had they given you a higher amount of drugs, would you have stimulated more? Of course, it's retrospective, but is it because of you weren't as responsive, the dose, or was it related to weight? So is it just a drug thing? Okay, well, next time we're gonna crank up that stimulation. Okay. Was it something like, miscommunication and they didn't comply with how to take the medications or took it the wrong time? Okay, let's better communicate so next time you do that. Was it just not the right cycle and you knew ahead of time? So for example, if someone expects a high number of eggs and we do the stimulation and we only see 4 follicles growing, did someone pause and say, hey, Caroline, you're understimulating compared to what we thought? Mm-hmm. It doesn't mean we won't succeed, but do you want to proceed, or should we cancel the cycle? Yeah. Because it's an expensive emotional turmoil, and try again. Somebody has to have the conversation with you. We can't assume that the patient knows that.
Yeah, of course. And we see that sometimes in if you have to cancel a cycle, that it can be very traumatic, especially when you've got these expectations. You've set out on this journey that's already very emotional. So I think that's a really important conversation, and building that relationship with your physician or your REI is so important. Yeah. To have that trust to be able to communicate back and forth.
Totally, but I want to hit a point home, is that it is expectation. So if you have 4 growing follicles, but that's what you expected, and that's what the patient knows to expect, and then it happened, you proceed. That was the right point. If you were expecting 20 follicles, that's not what was expected, you
Mm-hmm.
pause and make a decision together.
Yeah.
That's the big difference. Or same example, sometimes we got a whole bunch of follicles, but at the end of the retrieval, we only got a few eggs. And then we say, okay, was it something that the doctor couldn't get to the ovaries,
Mm-hmm.
or it was too painful? Was it something like, the trigger? We got to
Yeah.
look at each step to say, we think that's the problem. What are we adjusting next time? I mean, this is one of many examples because it really depends on the scenario. Okay.
Makes sense.
I think this is just unsolicited PSA to the people out there. Like, we all want you to succeed. No one is cheering for you to do another IVF cycle. The other part is what I preach all the time is like, persistence is critical for success. Okay. Like, somebody who's going to try 3 times is going to have more success than someone who's going to try once. Okay. To me, persistence, everyone has their limit on finances, physical, emotional, but I think the people who are the most prepared are the ones who are persistent, and the ones who are persistent eventually succeed. Okay. Can I give you a good example that I've seen? Okay.
That would be awesome.
So in Ontario, we have a funded program for one IVF cycle. Each clinic distributes it differently, but generally every clinic has a wait time. One thing that I've consistently noticed is the following. If your first IVF cycle is a funded cycle, great, let the government pay, and you succeeded, congratulations. If you did not succeed, only a small amount of people will try again, because in their mind, if it didn't work the first time, why would it work the second time? And now there's extra financial burden to it. I understand the logic, but I'm not sure someone explained the details to the patient.
That's a good point, actually, when you think about how patients may perceive that as, if it failed the first time, why would it work the second time?
Right.
Yeah, that's really...
So let me explain the reverse now. Now, what I've noticed for the last few years is, if the patient does not want to wait for funding and proceeds with a private IVF cycle, again, if they succeed, wonderful. I'm glad we didn't wait. The finances are worth it. If they don't succeed, and now they're presented with a second attempt, but it's funded, almost all of them try it. So funny enough, that second group, who's eventually trying twice versus one, are way more likely to succeed.
Wow.
And it's just because, there's a lot of layers to that, but it's super interesting.
Yeah, that is interesting.
So I think that's the key. So when I sit with a patient, my job isn't to say, of course it's going to work and we're just going to do that, it's a guarantee. No. Yeah. My job is to say, these are the variables we see. This is how we're going to optimize it. I think based on what we see, let's say we have a 35% chance of success, ballpark. And so I have to say the difficult discussion, Caroline, imagine it's going to take us 3 cycles. Statistically, it's going to take us 3 cycles. We're all aiming for success. We hope it's the first one, but mentally be prepared. And then you have a marathon mindset and say, like, if it doesn't work, we don't give up. I'm not saying blindly do the same thing 3 times.
No.
Yes, if it doesn't work, go back to the drawing board. What did you learn? But the key is, you were expecting that it might take a few tries. And those people eventually do way better than the people who just tried.
That's awesome. And I hope that people watching listen to that and sort of take that back and think about it.
Yeah. The other thing, as long as is when you go for second opinions, I think it's great. Get different opinions. Most of the time, there isn't a correct treatment. I think if there was a correct treatment, we probably would all end up there. I actually think it's, especially in fertility, it's very frustrating for patients because, I joke that there's 3 doctors and 4 opinions. And some people say, okay, increase that stimulation, or the opposite, you got to decrease that stimulation, or you got to go longer, or you got to go shorter, or you got to do this, or you got to do that. The truth is, we don't know the answer. Otherwise, we would all do it. But as long as it makes sense, it's logical, and I think has no risk to it, it's between you and your doctor.
That's a great way to think about it. I've got a couple of questions coming in. I think some of them can be asked now. When, in your medical opinion,
should I go back to that first question? I just don't want to miss it.
Yeah, we can go. Actually, you can go back there. Do you want me to? I'll read it to you. Hold on, just so that we know the exact details. So going back to the first question, after having a failed IVF cycle, 15 eggs retrieved, 14 fertilized, 0 blasts. How long would you say a person should wait between trying again? I guess what I want to know is how much time is needed to improve egg quality, and can egg quality be improved if eggs are granular or slow growing?
So I'm happy to answer that, but I hope everybody who's listening understands it's a complex scenario, and my simplified 1 minute answer doesn't do it justice.
Mm-hmm.
But I'll go back to the seed and soil analogy that I like to use. That is a perfect example where it's clear that the issue is probably in the seed. We didn't even get to the transfer part, right?
Mm-hmm.
So, when, I don't know this person's history, but let's say they've never gotten pregnant. I think we have some insights into why we've never made a good enough embryo. Okay. Now the question between the patient and the doctor is this egg related or is this sperm related? It sounds like they think it's egg related. And then the question is like, okay, so what do we do next? So in the extreme backup, we're talking about egg donor. But I think everybody would say, wait a minute, only 1 cycle, stimulates well. These things happen. You can't give up after 1 cycle. I think that's what most fertility doctors would say. The question what to do next, again, that's where you're going to get like a wide variation. So some people say change the lab. Maybe they were great eggs, but they didn't grow so well in that lab. Some people say change the protocol, stimulation up or down. Some people say, hey, focus on egg quality. Now, in terms of egg quality, the crazy part about egg quality is we have no measurement for egg quality.
Mm-hmm.
We have no way of taking a blood work or an ultrasound and say, hey, you've got, really low quality eggs, or actually you've got fantastic eggs, right? The only time we get to see the eggs is during IVF. So then we have some insights. But even in IVF, there is no egg scoring system, right? Whereas in an embryo, you can say this is a 4AA and this one's a 2BB. In eggs, we don't say this is a 9 out of 10 and this is a 1 out of 10.
Right.
So it's kind of like indirect assessments, okay?
Mm-hmm.
But in terms of egg quality, I think most of us would say that a lot of it you cannot change, your age, your genetics, but you should just focus on the part that you do have control over. We call it like epigenetics. You don't, like, the analogy is you don't determine your genes, but you probably have control of which genes get turned on and off. So some of this is obvious stuff, but they're important. The stress, the sleep, the diet, the nutrition, the supplements. When we talk about supplements, we generally talk about mitochondrial supplements because mitochondria is a key part to the egg and the cell division. I never say these are like magical pills and you can't succeed without it. But again, it goes back to the first pillar, optimization.
Mm-hmm.
So generally, you need to go back to your doctor and come up with a plan what you're going to do different. But if you're talking about what you could do lifestyle-wise, we generally think that the egg cycle is about 2 to 3 months. So those all on ultrasound, those follicles you see today probably started growing 2 months ago. So we sort of say, hey, if you're going to focus on making big changes, give yourself 2-3 months before jumping into it.
Okay. Just an update on that specific person. She has been pregnant 4 times, 2 miscarriages before 9 weeks, and 2 chemicals.
Okay, well that adds more information to the story because
Mm-hmm.
if you've ever been pregnant, whether it's a chemical pregnant miscarriage, by definition, you had an embryo that hatched and implanted, which is different from what happened to IVF. So this is a perfect example where I would tell that patient, oh, like that could have just been a cohort because like in the past you have made an embryo. Like you don't give up hope and you keep going. Whereas
Awesome.
if they've never gone pregnant, I'm more scared that what if they've never made a blastocyst?
Right. But we can confirm at least 4 times.
Yeah, if they've had a pregnancy, by definition, that's a blastocyst that's implanted.
That's great. Can anything be done for failed implantation? We had 2 failed euploid normal embryos not implanting, resulting in a failed IVF.
Yeah. So again, seed and soil, it sounds like in this scenario, we're talking about, hey, we can generate nice embryos. One thing the doctors will tell you is chromosomally normal embryos are a prerequisite. You need that to succeed, but it's not the only thing. Okay.
Mm-hmm.
So we also look at the grading of the embryos, what it looked like after thawing, the development milestones. But assuming you had two beautiful, perfect embryos and it's not implanting, then you're thinking about the seed, or sorry, the soil. again, every physician has their own sort of assessment. If I can break it down, I think the first thing we do is structurally.
Mm-hmm.
Structurally, is there anything in the uterus that we think could be decreasing your chance of success? Were you born with a structurally unusual uterus? Are there things inside like scarring, polyps, or fibroids? Then we look for things like endometrial thickness. How thick can it get? What's the pattern that we see? How does it respond to progesterones? There's some interesting endometrial biopsy analysis we can do. So there's a whole bunch of stuff. But I guess my takeaway point is not so black and white, right? It's not, we're all hoping that we find one specific thing, turn it left, and now it's going to work. It's logical to approach it that way, but it's not always the answer.
Okay. If a patient was to successfully conceive but unfortunately had a loss, unrelated, would that be still considered a successful cycle? So I guess it's a successful cycle. They successfully conceived, but then experienced a loss of that conception after that conception.
I think it depends on your perception. I think most people would say no, because it wasn't really the outcome we were all hoping for. But for me as the physician, it definitely hit a few milestones. So there's a lot of success in there. And as a general rule, the further you can get to, the more likely eventually it's going to succeed. One thing that I think is underutilized or talked about is when you have a miscarriage, there are opportunities to actually test the chromosomes that led miscarriage. We assume that every miscarriage represents an abnormal embryo, as in the chromosomes are off. We don't know that for sure. We're just talking statistics, but I think that's quite insightful. So for my patients who've had miscarriages and I can test it, and let's say it comes up that, look, this is missing a chromosome, I think everybody knows that it wasn't the stress or the Chinese food or the sex or that the doctor didn't adjust your thyroid or it wasn't enough progesterone. It was, we're waiting for that right seed. And I think it's very insightful.
If someone has a miscarriage, because I've seen this pop up in several talks I've done. If you're experiencing a miscarriage, how would you let someone know that you'd like to get, and excuse me, I don't actually know the right terminology, the tissue or the material tested for that?
Yeah, I mean, it's not something that the patient can do, so it's not like a direct to consumer. Usually you'd have to go through your doctor, and if someone is already plugged into a fertility clinic, that's a relatively easy thing for them to coordinate. If you're doing if you're managing the miscarriage, let's say at home, then there's kits that we can provide for you. The downside is it's pretty involved. You do have to collect it and put it in and send it off, although we provide the kit. If you're having a procedure to deal with it, depending on where you're having it, usually they can take that tissue and ship it off for you.
Okay, great. That's good information. I once heard fertility treatments referred to as trial and error, and unfortunately an expensive trial and error, as there's no right fix. And each person's needs are different and their bodies respond differently. What are your thoughts around this, and would you agree?
I think in theory I agree, but you're right. We need a better PR name than trial and error.
Agreed.
We have to rethink that name. I think what they're trying to say is we're aiming for optimization. We expect a certain outcome, and then we see what really happens, right? I agree that there isn't a for sure treatment plan, or otherwise, you wouldn't need to talk to your doctor. There would be a robot that types in 37-year-old AMH of 1, sperm count of 11 million. She needs this.
Yeah. When, in your medical opinion, would be the time where you would suggest it's best to cancel a cycle?
An IVF cycle? Again, to me, the key is when the expectations and what we're seeing don't match.
Okay.
So if we expect one growing follicle and one egg, and the doctor's aware of it and the patient's aware of it, and then we start the drug and we see one growing follicle, we proceed. If we expect a whole bunch of follicles and so does the patient, and for whatever reason there's only one growing follicle, I cancel it. Okay. That's probably, most cancellations are related to stimulation expectations, but sometimes we cancel it because something in the blood work or ultrasound looks unusual, but those are a bit more rare. It's usually about how you stimulate, because we actually can't see the egg. So I see follicles. This one's 22, this one's 19, but I can't tell you if that 19 has a good egg or something like that.
Yeah. Okay. Thanks for that. That's all the questions for right now. I don't know if you have more slides or.
No, those are my main slides.
Okay, perfect.
Yeah.
Do you have, so in sort of, as we're getting to the top of our time, if you're watching live, please, you've got a couple more minutes to send in your questions for Dr. Nayat. But in kind of closing, as we sort of wrap things up, Dan, is there anything else that you think is important for patients to consider or to know?
The other thing I always see, not always see, but I see quite a bit, is patients don't follow up when sort of the last, bad news comes in.
Mm-hmm.
And I think it is informative, because sometimes there's other things to consider, but you don't get that feedback unless you go back.
So that's actually, I did think of this question for you earlier. Quite often, and it may come back to expectation or assumption, we will see in support groups the question, how long should I wait for the clinic to call me for my follow-up appointment after a failed cycle?
Right.
So I think there's probably a misunderstanding, a miscommunication, and an assumption that the clinic's calling. And we always say, you have to advocate for yourself, make the phone call,
Right.
and have the discussion with your specialist so you know exactly, you can figure out what happened, you can make plans for the next steps, those types of things.
It's a good logistics question that I don't know the answer to. I think most clinics sort of leave the ball on the patients.
Mm-hmm.
Like they say, you just got bad news. Everybody deals with that differently. If you feel when you're ready, we're here. So it's kind of like up to you. And sometimes that patient may misinterpret that as like, we don't want to see you, or there's nothing to talk about,
Mm-hmm.
or a non-caring clinic. But so I don't know. I don't know if we should automatically book patients for a follow-up and let them decline if they want to. It's a good question.
Yeah, actually, and I think that I'll take that actually back into something for us, number one, to educate our patients and our followers on social media about. It's a good thing to say, you need to advocate. If you're not hearing, assume they're not going to call, but also a good opportunity for us to reach out to the clinics to say, listen, patients, in our experience, patients are talking about expecting this phone call. It might be something you want to consider internally booking this sort of follow-up visit, sort of maybe within a week, or like book, at least having it on the schedule within a week after receiving some news about a failed cycle.
Yeah.
I have one more questions come in. After a failed cycle, are there tests you would recommend patients to have done in order to develop a plan for a second attempt?
Give me 1 second.
Yep, that's okay.
So the question is, do you have to wait until a failed first cycle and to individualize the approach a second time? Yeah. So I think the question is, why aren't you just individualizing it the first time? Which kind of goes back to someone's comment about trial and error. I think the doctors are trying to individualize it.
Mm-hmm.
When you come up with your plan, some of those plans are, should we test these embryos or not? Should we do a fresh transfer or freeze-all? Should we do 1 embryo or 2 embryos? So should we use extra things in the lab like sperm selection tools or special incubators? So probably that individualization is happening, but you don't have the same amount as data because you've never seen the egg and the sperm react and grow.
Got it. Do blood thinners change how your endometrium thickens for an IVF cycle?
Good question. In my opinion, no. I think when we talk about blood thinners, so ideally the treatment you have is related to the problem you have. Mm-hmm. So generally blood thinners should be for someone who's got a clotting issue or a microclotting issue, or at least that's what you're thinking. Mm-hmm. But sometimes we use blood thinners because it might have other impacts. In my opinion, whether it improves implantation is a different discussion, but if it does, some of the blood thinners like Fragment have like immune modulating properties. So I think that's where I sort of see the potential benefit instead of just thickening the lining. And again, line thickening is an important variable, but it's just one of many, like pattern and
course.
how dynamic it is and stuff like that.
Great. All right. Well, we are out of time for today's session. I appreciate you being here. And I know that you've got to run off to patient care right now. Sorry. Thank you to everybody who's joined us live for another episode of Figuring Out Fertility. Don't forget, it is Canadian Infertility Awareness Week. We were just speaking with Dr. Dan Nayad, who is the medical director of the Fertility Partners and reproductive endocrinologist at RCC in Mississauga. Dan, how can people find you if they want to get in touch?
On the RCC website, it's probably the easiest. We have a pretty cool self-referral program, which makes it easier, especially during this pandemic. And I think you could just email info@rccfertility.com.
Yeah, and it's the Reproductive Care Center in Mississauga. That's what RCC stands for. So thank you, Dan. Thank you for your time. We look forward to another chat in the near future with you. For everybody that's been watching, we appreciate it, and we hope that you're enjoying Canadian Infertility Awareness Week.
Thank you. I have a nice background, but yours is actually a real one, and it's beautiful.
Oh, thanks.
Yeah.
Thank you. I would like to have one like yours. I'm going to have to go to the Fertility Partners team to see how I can get one too.
Have a great day. I'll see you in a bit.
Okay. Bye.
Bye-bye.